Hello, I'm Rajat Chand. I'm a media correspondent with SIR here in Atlanta for SIR 2015. I'm standing here with Dr. Sheena Pimpalwar. She's an interventional radiologist at Texas Children's Hospital in Houston, Texas. And a part of the vascular procedures workshop, she was speaking about hemoptysis in children. Dr. Pimpalwar, you had a great talk. You discussed a lot of great things about the anatomy and pathophysiology, as well as the pre-procedural planning, and as well as your technique in bronchial artery embolization. I was just wondering if you could tell for us some of the key takeaway points for trainees to know about this specific type of disease and procedure in children.
Sure. Thank you, Rajat. Thank you for talking to me. I had a real good presentation and a very good response from the audience. It was a good experience. Hemoptysis in children is usually from chronic lung disease such as cystic fibrosis, which is a commonest cause. And when they come with a big bout of hemoptysis, which we consider more than 300 ml per day, or more than 8 ml per kilo per day, it's important that you rush them into quick management by IR into a bronchial artery embolization procedure without delaying trying to get a CT chest or CT angiography or bronchoscopy done if you know the diagnosis already, because these children could die from just swallowing or asphyxiating on the blood that they are coughing up. So it's important, the time management is very important. If you don't have that big an amount of hemoptysis, then you have more time at hand to do more diagnostic tests or work up the cause of hemoptysis. So the urgency is important to understand. In the technique, we use bony landmarks, use the carina as a landmark to find that bronchial artery. You'll find that if the artery is enlarged, you will just simply fall into it effortlessly. And when you do your angiogram, try to look for anomalous connections between the bronchial artery and the pulmonary artery, or bronchial artery and pulmonary vein, or a systemic artery, so that when you embolize, you don't cause damage to other organs like stroke or blindness, or some blue toes from particles going down into the legs. So those are important things.
Great.
And embolic agents are typically particles, but sometimes you have to use larger particles or liquids if you identify large shunts between the bronchial circulation and the pulmonary circulation. We rarely do an aortogram because all it does is just waste some time and contrast and radiation. We only do aortogram if we are in a situation where the patient has rebled in spite of a good embolization recently, where we are now looking for non-bronchial systemic arteries feeding the lung or ectopic bronchial arteries. So the regular bronchial arteries are very easy to catheterize.
Great, Dr. Pimpalwar. Thank you so much for your time. That was a lot of rich information, and thank you very much.
Thanks a lot.